harsh. Okay, it's in that box. Okay. A delay in the coronary perfusion. A delay in the coronary perfusion more than 24 hours from symptom onset correlates with extensive myocardial death. Extensive myocardial death increases the risk of mechanical complication following acute myocardial infarction. Interventricular septal rupture. Interventricular septal rupture occurs typically 3 to 5 days following a large MI involving the LAD or RC. Communication between the left and right ventricle. Communication between the left and right ventricle leads to increased pressure and volume load on the right ventricle and results in acute right-sided and left-sided heart failure. Patients develop acute cardiogenic shock. Patients develop acute cardiogenic shock, pulmonary edema, hypertension, confusion due to poor organ perfusion, and demonstrate jugular venous distension and hepatomegaly due to liver congestion. In addition, blood flowing from the left to right ventricle. In addition, blood flowing from the left to right ventricle a harsh holosystolic murmur creates a harsh holosystolic murmur with a palpable thrill that can be appreciated at the left sternal border. The diagnosis of the interventricular septal rupture. The diagnosis of the interventricular septal rupture can be confirmed by pulmonary artery catheterization detecting a left to right shunt with a step up in oxygen saturation from the right atrium to right ventricle, or by transthoracic echocardiography with visualization of the septal defect. Okay, it's not papillary muscle rupture. Option E, papillary muscle rupture leads to acute severe MR, presence with sudden onset hypertension, dyspnea, pulmonary edema. Compared to interventricular septal rupture, the systolic murmur of acute MR is soft and there is no palpable thrill is present. In addition, left anterior descending lesion as in this patient is more likely cause septal rupture rather than papillary muscle rupture. And if you read the location, a harsh look at the question. They said that a harsh, loud, hollow systolic. Okay, hollow systolic murmur is MR, TR, and VSD, but MR is usually in the mitral area, isn't it? It is not at the left sternal border, and it does not come with a palpable thrill. So it's not MR, and we know that in papillary muscle like PROM, papillary muscle RCA, there is MR, and that murmur is soft systolic murmur, soft systolic murmur, but it is new harsh hollow systolic murmur with a thrill. Okay. Okay. This patient this patient has multiple risk factor for atherosclerosis. This patient has multiple risk factor for atherosclerosis, like diabetes, hypertension, smoking, diabetes, hypertension, smoking, consistent and symptoms consistent with intermittent claudication. The next step in the management should obtain the physiologic testing of ankle brachial pressure index to confirm the presence of peripheral arterial disease as a cause of his symptoms. Ankle brachial index is an inexpensive and non-invasive vascular test. Inexpensive and non-invasive vascular test used to confirm the diagnosis of peripheral arterial disease as in this patient. It is defined as the ratio of the systolic blood pressure of the ankle to the ratio of the systolic blood pressure of the ankle to the systolic brachial blood pressure. An ankle brachial index, if it is less than 0.90, it is considered as diagnostic of occlusive peripheral arterial disease with 90% sensitivity and 95% specificity in symptomatic patient. So if patient has multiple risk factor like atherosclerosis, diabetes, hypertension, smoking, Along with intermittent claudication, look for ankle brachial in pressure index. Is it seen like normal BP cuff? Okay. Yes, because brachial systolic blood pressure easily can be calculated by the normal BP cuff. I am thinking about just ankle. Okay, okay, it's normal BP cuff then. Yes. Okay. Lab evaluation of hypertension is there are some routine tests for evaluation of hypertension. Renal function tests. Renal function tests serum electrolyte, creatinine, urine analysis, urine, albumin, creatine ratio, which is optional. Endocrine tests like fasting blood glucose or HbA1c, lipid profile and TSH. Cardiac tests is ECG and echo, and other tests are like complete blood count or uric acid. The initial evaluation of hypertension is directed to identify the complication of hypertension or comorbid conditions that might influence management. Baseline management should include serum chemistry panel include serum chemistry panel including electrolytes and creatinine and hemoglobin or hematocrit. Urine analysis to exclude hematuria and evaluate for proteinuria, and ECG to screen for left ventricular hypertrophy or prior MI. Some experts advise measuring serum TSH because thyroid disorders are common and increase the risk for hypertension. Thyroid disorders are common and increase the risk for hypertension. In addition, patients with hypertension are increased risk for ischemic heart disease and should be screened for other major atherosclerotic risk factors. A lipid panel is recommended and patients should be screened for diabetes mellitus with either fasting blood glucose, which may be obtained as a part of standard serum chemistry panel, or HbA1c. Because primary hypertension is much more common than the secondary hypertension. Further diagnostic evaluation is indicated only in patients with atypical presentation onset at age less than 30, resistance hypertension requiring more than 3 medication, signs and symptoms suggesting of specific etiology. Okay, It's not 24-hour urine cortisol excretion, uh, which is used to test for Cushing syndrome. However, Cushing syndrome typically presents with characteristic examination finding central obesity, abdominal stria, facial plethora, not present in these patients. Got it? Okay. This patient with recent history of uveitis and uveitis has mild dyspnea and 2 week history of pre-syncope episode. 2 week history of pre-syncope episodes likely due to conduction abnormality given her marked bradycardia with AV block and left bundle branch block. She most likely has sarcoidosis with cardiac involvement. She most likely has sarcoidosis with cardiac involvement. Autopsy studies have suggested evidence of cardiac non-causating granuloma. Cardiac non-causating granuloma at least 25% of the patients of sarcoidosis. However, only 5% patients demonstrate signs and symptoms of cardiac involvement, suggesting cardiac sarcoidosis is underdiagnosed or remains subclinical. Infiltration of non-causating granuloma leads to surrounding in, infiltration of non-causating granuloma leads to surrounding inflammation uh, and can result in conduction defect. Complete AV block is common. Restrictive cardiomyopathy, early manifestation, dilated cardiomyopathy, late manifestation, dysfunction and heart failure, valvular dysfunction and heart failure. Sudden cardiac death can occur due to complete AV block or ventricular arrhythmia. Due to complete AV block and ventricular arrhythmia, cardiac sarcoidosis should be suspected in any young patients. In any young patient age less than 55 with unexplained second uh, cardiac sarcoidosis should be suspected in any patient age less than 55 with unexplained second or third degree heart block, or when ECG change occur with known or suspected or ECG change occur with known or suspected systemic sarcoidosis, dyspnea with midfield, lung opacity, uveitis. Definitive diagnosis can be challenging due to poor sensitivity of endomyocardial biopsy, but a combination of imaging findings, ECG findings, and history. Combination of imaging finding, ECG finding, and history suggests the diagnosis. History suggests the diagnosis. Got it? Okay. It's HCM, hypertrophic cardiomyopathy, Valsalva abrupt standing, and nitroglycerin administration. Valsalva abrupt standing and nitroglycerin administration actually decreases preload. If there is decreased preload, decreased left ventricular blood volume, which will increase the murmur intensity. And sustained hand grip, squatting, passive leg raising, uh, it actually increase the preload and afterload, so it will decrease the murmur intensity. So vans like Valsalva abrupt standing and nitroglycerin administration, decreasing preload, increasing the murmur intensity. Sorry, I remember in my style always. Yes, abrupt standing and the nitroglycerin. These three has decreased preload, so these three will increase the murmur intensity. S is for the just for remembering. Like van, you can say van. I say just vans. And the S and the last S actually I remember the for the rest of the three for SSP like sustained, hand grip, squatting, and passive leg raise. That's why I remember the Vans. So S for the rest of the part. Okay. Uh, so actually, DASH diet, like dietary approaches to stop hypertension, like diet high in fruits and vegetables, low in saturated and total fats, low in saturated and total fat. This DASH diet approximate decrease of systolic blood pressure is 11 millimeter of mercury. And the next one is weight loss, 6 millimeter mercury per 10 kg of weight loss. And then aerobic exercise more than 30 minutes per day for 5 days a week, it approximately 7. Dietary sodium actually 5 to 8 millimeter, and alcohol limitation less than 2 drinks per day in men, less than 1 drinks in women, approximately 5 millimeter of mercury. So highest is the DASH diet, then weight loss, then aerobic exercise, then weight loss, and then sodium and alcohol. Got it? Okay. Other option like choice B, moderate intensity aerobic exercise can lower blood pressure in both hypertensive and normotensive individuals and facilitates weight loss. However, weight loss has greater impact on blood pressure than exercise alone. Daily heavy alcohol consumption more than 3 drinks per day in men and more than 2 drinks in women, or binge drinking can raise blood pressure and is a common cause of refractory hypertension. Hypertension that remains uncontrolled despite multiple medication. However, moderate alcohol intake, as in this patient, does not significantly affect blood pressure. Choice D, sodium restriction can lower blood pressure when implemented as part of the DASH diet. Low in sodium saturated fat, low in sodium saturated fat, and high in the potassium, calcium, or dietary fiber. Sodium restriction alone is somewhat less effective and inconsistent with the greatest effect in individuals aged more than 65. The African American population and patients with chronic kidney disease. Smoking cessation is an important component of lifestyle modification that reduces the risk of future cardiovascular event and all cause of mortality. Okay, okay. So cardiac risk index. Revised cardiac risk index. There are six risk predictors like high risk surgery, vascular or intrathoracic. High risk surgery, vascular or intrathoracic. Ischemic heart disease, history of congestive heart failure, history of stroke or MI, diabetes mellitus treated with insulin, and preoperative creatinine if it is more. Risk of cardiac death, non-fatal cardiac arrest or non-fatal MI. 0 to 1 factor, low risk, more than 2 factor, it is elevated risk. More than 2 factor is elevated risk. So all patient being considered for non-cardiac surgery, should undergo pre-operative cardiovascular risk assessment. Pre-operative cardiovascular risk assessment with validated prediction tool that incorporates both procedure and patient-specific variables. Although newer models, American College of Surgeons surgical risk calculator are available. The revised cardiac risk index remain widely accepted due to its long validation and simplicity. 1 point for each and 6 risk predictor. The undergoing intermediate risk procedure with no patient risk or intermediate no patient's risk and has an uh, ha, no patient specific risk has an RCRI score 0, so it is intermediate risk. So the operation should be the OT should be in between head, neck, or orthopedic or prostate, isn't it? High risk level is aortic, intrathoracic, and open intraperitoneal. And the low risk is breast cancer endoscopy procedure and the cataract extraction. Okay. In contrast, when estimated risk is more than 1%, that means reverse revised cardiac risk index. Revised cardiac risk index is more than 2. Further preoperative evaluation requires for the assessment of cardiac functional capacity. Functional capacity is classically determined based on the ability to perform activities four met score more than 4 met score. Okay. uh, Less than 4, look at the met score. Less than 4 is eat or dress or toilet, walk indoors, in house, do light housework. If they can perform these works, so it is less than 4. And more than 4 is climbing a flight of stairs, run a short distance, do yard work, participate in golf, tennis, or dancing. So patients with increased risk, more than 1% who can perform more than 4 met can proceed to surgery without further evaluation. Patients with increased risk, more than 1%, unknown or poor, less than 4 met, functional status require further consideration. Cardiac stress testing is the condition if cardiac intervention is necessary will impact the surgery or perioperative management. Postponing elective surgery for revascularization followed by 6 months antiplatelet therapy. Because these patients are typically less likely to achieve adequate exercise workload, pharmacological based testing is recommended over exercise based testing. Okay, you want me to read the other options too? Yes. Okay, coronary angiography is indicated in patients with acute MI. In acute MI, unstable angina, abnormal stress testing, patients has an anginal symptoms making coronary angiography unnecessary. And preoperative resting echocardiography is generally necessary only if uh, only if indicated the absence of planned surgery like new murmur, clinical status changes in patients with heart failure. The patient's preoperative assessment shows an evidence of heart failure or valvular disease, no dyspnea or murmur. Okay. Again, what you have said again for MI. Yes. Yep. Continuous murmur. Ejection systolic murmur is ASPS ASD and ASD. But there is increased thickness in the interventricular septal wall, not interatrial septal wall. No, 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 no. It's not look like AC. Or it may be HCM. As because the mother is diabetic. Uh, HCM can come with multiple murmur. Yes. Okay, I am reading the box first, then I'll read the explanation. Okay, hypertrophic cardiomyopathy in infants of the diabetic mother. Hypertrophic cardiomyopathy in infants of diabetic mother. If there is maternal hyperglycemia, it will cause fetal hyperglycemia, fetal hyperinsulinemia, and there is increased glucagon and fat deposition in the interventricular septum, and this causes dynamic left ventricular outflow tract obstruction. It is often asymptomatic, may have respiratory distress or hypotension, and it can come with systolic ejection murmur. Chest X-ray show cardiomegaly, echo show increased thickness of the interventricular septum, and decreased left ventricular chamber size. Treatment is IV fluid and beta blocker to increase left ventricular blood volume. Spontaneous regression by age 1. So this newborn has mild respiratory distress and a systolic ejection systolic murmur with sonographic evidence of interventricular septal thickening consistent of hypertrophic cardiomyopathy. Infants of mother with gestational diabetes are at risk of developing transient form of HCM. Exposure to excess glucose in the utero leads to fetal hyperglycemia, hyperinsulinemia, and increased fat and glycogen deposition that is prominent within the interventricular septum cardiomyocyte causing HCM. Although most affected infants are asymptomatic, some develop heart failure. Some develop heart failure due to left ventricular outflow tract obstruction, respiratory distress, hypotension, ejection systolic murmur. Other neonatal consequences of the maternal diabetes may not be present, such as macrosomia, plethora, or due to polycythemia. Okay, look at the box of the like neonates consequence of maternal diabetes. Just remember, first trimester is CNS, like congenital heart disease, neural tube defect, spontaneous abortion, and small left colon syndrome. First trimester is CNS. Second and third trimester is hyperglycemia and hyperinsulinemia. We know that we actually do the OGTT and the first HbA1c in the second trimester in the pregnant lady, isn't it? So that's why fetal hyperglycemia and hyperinsulinemia. Remember, fetal hyperglycemia and hyperinsulinemia from second and third trimester, and CNS for first trimester. Okay. And fetal hyperglycemia, hyperinsulinemia, it can cause polycythemia, it can increase the organomegaly, it can cause neonatal hypoglycemia, it can cause brachial plexopathic clavicular fracture, and it can cause HCM due to increased glycogen synthesis, glycogen deposition in the interventricular septum, which causes HCM. Got it? Okay. So management of systemic HCM is aimed at increasing left ventricular volume in order to alleviate left ventricular outflow tract obstruction and improve cardiac output. It includes IV fluid and beta blocker propranolol. Beta blocker reduce heart rate, which increase the left ventricular diastolic filling time, as well as um, end diastolic volume preload. In addition, the negative inotropic effect of beta blocker decrease pressure gradient between the left ventricular outflow tract and aorta, further reducing the dynamic left ventricular outflow tract dysfunction. Treatment is rarely required for than more than a few weeks because the insulin levels quickly normalizes, leading to reduced septal thickening and self-resolution. Got it? Yes. What is the ECG diagnosis? It's actual uh, irre- irregular rhythm, AFib or atrial flutter. It is atrial flutter. Wait, whenever you find atrial fibrillation or atrial flutter, whenever there is irregular pulse and it is non-valvular atrial fibrillation, what you have to do? Yes, you have to do Chadsworth. And anticoagulant is the number one because look at the age of this young man, like 75. So he got the 2 point already, and he's man, he got the 3 point. We do not need to see anything. So it's actual flutter, sawtooth appearance. Look at the ECG now, sawtooth appearance. You have seen the saw, isn't it? Which yes. So the tooth of the saw is looks like atrial flutter. So atrial fibrillation, atrial flutter, all goes to the criteria of the atrial fibrillation, Chadsworth. If Chadsworth show more than 2 in case of men, it is positive, go for anticoagulation. That's it. He has like look at the age. Age is more than 75, so he got the 2 point. And he is men, six category, if six category female, you need 3 point. If six category male, you only need 2 point. Yes, but non-valvular. If it is valvular, then go for warfarin. Sorry, I have seen just two things. I have seen the pulse, irregular pulse. Irregular pulse comes with what? Atrial fibrillation, atrial flutter. It has only two diagnoses, irregular pulse. Okay, next I have seen the ECG. In ECG, it is atrial flutter. Look at the ECG. Rhythm is irregular. If P wave absent, rhythm irregular, uh, that is atrial fibrillation or atrial flutter. Whenever you find a patient with atrial fibrillation, first you need to do a scoring for first you need to do scoring. Why? You will give anticoagulant or not. Then you will give rate control therapy. You will give rhythm control therapy. That is the treatment of the atrial fibrillation, isn't it? So this is a plus, like the main treatment of the atrial fibrillation is rate control, rhythm control. If it is active, like he comes with shortness of breath, palpitation, high pressure, and you do ECG, there is atrial fibrillation. Then you first need to control the rate. That means you need to control the pulse. You need to control the rhythm. So rate controller therapy, rhythm controller therapy. If the patient is hemodynamically unstable, then you can go for other defibrillation. No, no. Uh, First, whenever we are assessing the patient, is it, whenever we assessing the patient, some like a patient comes to you and he complains of the shortness of breath, palpitation, these and that. What actually we do? We just touch the pulse, we see the BP, and we do a ECG. Whenever you touch the pulse, if the pulse is irregular, the first thing strike in your mind that it may be atrial fibrillation. How will you confirm? By doing an ECG. In between that, like if the rate rhythm is different, irregular, and you do the ECG, atrial fibrillation is positive. Now you need to give the treatment. So what are our options? Rate control therapy, rhythm control therapy, and additional therapy. And what is this additional therapy? This additional therapy is oral anticoagulant. Yes, B- but whenever we are assessing, we are assessing as a whole, like we are doing ECG, and whenever we find that there is ECG change, we actually we then do the Chartsback score along with the ECG. Got it? It's a scoring system. You can do it by yourself, or you can use the calculator, like med calculator. There are plenty of calculator, med calc. You can use, sorry, yes, okay. So he look at the question again. So he is older. He he has CABG. 6 months ago, he has CABG. Now the patient, this patient has chest pain that was bothering before the surgery. So this patient is not active AFib patient. Got my point? Like he has not come for active AFib treatment. He has atrial fibrillation actually before. Like look at the exertional chest pain bothering before the surgery, completely resolved. So he has problem earlier, and he is on the treatment of cardiac treatment. He's and on physical examination you find the irregular pulse. Okay. Livedo reticularis. So it's a livedo reticularis in the food finding, and there is blue toe syndrome also. This patient has this blue toe syndrome also. Okay. So this patient most likely atheroembolism, which uh, atheroembolism which results from disruption of the atherosclerotic plaque, disruption of the atherosclerotic plaque that leads to showering of cholesterol, microemboli, and debris into the circulation. The microemboli can cause partial or total occlusion of the peripheral artery with resultant inflammation and ischemia. Atheroembolism most commonly occurs following instrumentation of the aorta, cardiac catheterization, but can occur spontaneously due to rapid expansion of the atherosclerotic aortic aneurysm. Clinical manifestations of the atheroembolism. Clinical manifestation of the atheroembolism. Atheroembolism can be immediate or delayed by up to several weeks. Plaques in the aortic arch can shower into the brain, causing stroke or confusion, eyes causing vision disturbance, and bright yellow Holland short plaques on retinal examination. Holland horse Holland Horst plaque on retinal examination and upper extremity. Plaques in the descending aorta can shower into the lower body and can cause intestinal ischemia, pancreatitis, acute kidney injury, toe ischemia, distal pulses are intact because the microemboli occlude the peripheral microcirculation. Skin manifestation are the most common complication include blue toe syndrome, cyanotic toes with intact pulse, livido reticularis, reticular lacy, skin discoloration, erythema that blanches on pressure, gangrene or ulcer. Treatment of atheroembolism is primarily supportive with anti-inflammatory medications and reduction of the atherosclerotic risk to prevent recurrence. Got it? Okay. So imagine this patient has like syncope. Like the patient's presentation is classic for vasovagal syncope, the most common type of reflex syncope. Vasovagal syncope typically involves a brief loss of consciousness, 1 to 2 minutes, preceded by trigger emotional stress while rushing for the bus and a vagal prodrome or diaphoresis worm. Classic vasovagal syncope is usually diagnosed based on the history alone, but other causes of syncope that are either more serious or require intervention must be excluded. Cardiac syncope must be considered because it results from underlying cardiac diseases that may cause sudden cardiac death. It typically occurs within warning in patients. It typically occurs without warning in patients with structural heart disease, aortic stenosis, hypertrophic cardiomyopathy, or conduction disturbance, long QT syndrome, and usually suggested by systolic murmur on ECG abnormalities. The presence of a murmur should prompt further investigation with echocardiography, and ECG abnormalities should prompt further conduction system workup, 24-hour Holter monitoring. However, patients such as these one with a clinical history consistent with vasovagal syncope and findings to no finding to suggest cardiac syncope require no further cardiac workup. Got it? Next. Okay. Orthostatic syncope. Orthostatic syncope should be considered. Appropriate intervention, fluid resuscitation, medication discontinuation may be indicated. The patient is at risk of orthostatic syncope due to medications that impairs peripheral vasoconstriction like amlodipine. However, syncope occur when sitting and a vital condition not consistent with orthostatic syncope. Given the patient's classic finding for vasovagal syncope and low likelihood of cardiac or orthostatic syncope, she requires no further testing or intervention at that time. Okay, these young patients with exertional syncope, these young patient with exertional syncope and ECG monitor, ECG demonstrating T wave inversion in the lateral leads. So exertional syncope, T wave inversion in the lateral lead raise suspicion of hypertrophic cardiomyopathy. The systolic murmur characteristics of HCM is sometimes absent because a left ventricular outflow tract obstruction may be absent or only when or only present with exertion. ECG is usually abnormal. ECG is usually abnormal and may show left axis deviation or disruption in the depolarization prominent Q waves and repolarization T wave inversion. Syncope due to HCM is usually exertional and typically results from one of the following: reduced cardiac output due to right ventricular outflow tract obstruction, reduced cardiac output due to dynamic left ventricular outflow tract obstruction, exertion related factors, dehydration, reduced left ventricular filling time that lead to low left ventricular blood volume, which can exacerbate the obstruction and markedly reduce cardiac output. This mechanism likely explains this patient's episodes of exertional lightheadedness. Ischemia-induced ventricular tachycardia. Ischemia-induced ventricular tachycardia (HCM) causes increased myocardial oxygen demand, increased muscle mass, and reduced myocardial oxygen supply. Myocardial disarray with microvascular dysfunction even at rest. Intense exertion amplifies this oxygen supply demand. This oxygen supply demand mismatch can trigger ventricular arrhythmia. Left ventricular outflow tract obstruction causing reduced oxygen supply can further exacerbate this mechanism. Ventricular arrhythmia that does not terminate as it does with syncope is the typical cause of sudden cardiac death. HTM is diagnosed with echocardiography, which can demonstrate asymmetric left ventricular hypertrophy, primarily affecting the interventricular septum, dynamic left ventricular outflow tract obstruction, left ventricular diastolic dysfunction, and left atrial dilatation. Okay, next. The systolic murmur is loudest at the apex and it radiates to the axilla. Murmur radiates to the axilla. Is it MR? And he is not traveling outside the US like California. So not rheumatic fever, sorry, rheumatic valvular disease, isn't it? It may be MVP type, myxomatous mitral. It's not bacterial infection. It's not calcification. Okay, it's MVP type, myxomatous degeneration. Okay, got it. So this patient's systolic murmur at the based heart at the cardiac apex, laterally displaced apical impulse, and S3, consistent with severe MR. In medically resource countries, myxomatous degeneration of the mitral valve leading to mitral valve prolapse. Myxomatous degeneration of the mitral valve leads to valve prolapse is the most common cause of chronic MR. Myxomatous degeneration involves mucopolysaccharide deposition and collagen disruption, resulting in thickening and redundancy of the mitral valve leaflet. It can occur as an isolated valvular process or in association with syndromic connective tissue disease, Marfan syndrome, Ehlers-Danlos syndrome. Mitral valve prolapse is characteristically recognized at mid-systolic click, followed by a systolic murmur of the MR. If leaflet dysfunction is severe, the murmur can be holosystolic and the click is inaudible. The chronic severe MR leads to left ventricular volume overload with compensatory eccentric hypertrophy and lateral displacement of the apical impulse. And S3 is typical due to rapid diastolic filling of the enlarged left ventricle, backflow of blood into the left atrium increases left atrial pressure, causes left atrial enlargement with atrial fibrillation, commonly developing evidence by patients' intermittent episodes of fast and irregular heartbeat. Okay. 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 These patients low postductal like right foot saturation. Uh, these patients low postductal right foot saturation relative to preductal right hand saturation. So postductal saturation relative to preductal saturation, right foot and right hand is consistent with right to left shunt across the PDA. Because this patient has strong distal pulses. Because this patient has strong distal pulses, most likely diagnosis is persistent pulmonary hypertension of the newborn at birth. Physiologically elevated pulmonary vascular resistance PVR normally decreases with oxygenation and ventilation of the lung. In persistent pulmonary in persistent pulmonary hypertension of the newborn, also known as persistent fetal circulation, the PVR remains elevated. The PVR remains elevated. The deoxygenated blue crosses the pulmonary artery into the aorta mixes with oxygenated red blood pumped from the left ventricle, resulting in relatively lower postductal saturation. Risk factors for persistent pulmonary hypertension include conditions associated with lung hypoplasia, congenital diaphragmatic hernia, Potter sequence, infection, pneumonia, meconium aspiration. However, some patients have no identifiable cause and simply have a lower decline in the PVR, resulting in mild right to left shunts that can persist into the first few days of life, as likely in these neonates. Respiratory distress and cyanosis are common, but infants are asymptomatic. Some infants are asymptomatic. Yes. Okay. Right to left shunting across the ductus arteriosus have also occurs in conditions in which left ventricular left ventricular output is obstructed, such as coarctation of the aorta. However, these infants has diminished femoral pulses, often lower extremity pallor, due to decreased distal blood flow. The patient has normal femoral pulse. Our patient has normal femoral pulse, making hypoplasia of the aortic arch unlikely. Got it? Okay, it's a complication of CABG, like acute postoperative mediastinitis. It's a direct microbial or contamination of the operative site, complicates 1 to 2% of the cardiothoracic operation, involving sternotomy. 1 to 2 weeks after the operation, sepsis, signs of sternal wound infection, drainage, tenderness, and chest X-ray shows with or without mediastinal fluid or ear. Characteristics: clinical presentation, surgical exploration revealing pus in the mediastinum, IV antibiotic with surgical debridement. So these patients are presentation dyspnea, tachycardia, fever, chest pain, tenderness, leukocytosis following recent cardiothoracic surgery is concerning for acute postoperative mediastinitis. The condition resulting from direct microbial contamination of the operative site and complicates 1 to 2% of the sternotomy procedure. Staph aureus is the most common causative organism, but gram-negative, Pseudomonas, coagulase negative, staph, and streptococcal organism are also account for important number of cases. Postoperative mediastinitis usually presents 1 to 2 weeks following surgery with sepsis and with sepsis accompanied by signs of infection of sternal wound, increase in seasonal drainage, cellulitis, chest pain, tenderness. Chest X-ray may reveal localized fluid or air bubbles within the mediastinum. Bacteremia is often present, and blood culture are frequently positive. Initial management involves broad spectrum IV antibiotics from surgical intervention, debridement of the mediastinum. The finding of the pus within the mediastinum confirms the diagnosis. Even with appropriate treatment, the associated morbidity and mortality are substantial. 15% mortality rate. Got it? Okay. You want to stop here or you want to continue? No, no, I don't have problem. We will finish 20 or we can stop here. You are very sleepy, yes. Okay, okay, okay. So he has chronic hypertension, isn't it? So chronic hypertension can cause S4. Concentric left ventricular hypertrophy, chronic hypertension. Okay, this present okay. We these patient These patients' substantial chest discomfort, left-sided neck pain, diaphoresis, and dyspnea are consistent with acute coronary syndrome. In ACS, myocardial ischemia leads to depletion of the ATP. Myocardial relaxation diastole is an ATP-dependent process. Myocardial ischemia causes left ventricular walls to become stiff and unable to relax. Therefore, atrial contraction Therefore, during atrial contraction, blood strikes against the stiffed left ventricle and creates a fourth heart sound S4 In most patients with acute myocardial ischemia induced myocardial dysfunction. So S4 frequently heard in patients with decreased left ventricular compliance, including those with concentric left ventricular hypertrophy like hypertensive heart disease, aortic stenosis, and restrictive cardiomyopathy. A soft S4 can also a soft S4 can also be a normal finding in the elderly age more than 70 due to a physiologic age-related loss of ventricular compliance. Okay. Next, next. Oh, left ventricular hypertrophy may be found upturning of the cardiac apex. Maybe. Okay. This patient most likely has coarctation of the aorta, a usually congenital narrowing of the descending aorta, typically located just distal to the left subclavian artery. The narrowing creates a the narrowing creates a proximal arterial pressure load affecting the upper body. Patients can sometimes present in adulthood, typically with asymptomatic hypertension of the upper extremity, less often with accompanying epistaxis and a headache. There may be systolic murmur due to blood flow through the constricted aorta, heart at the left infraclavicular area anteriorly and the left interscapular area posteriorly, sometimes difficult to auscultate in the supine position. The murmur may be continuous if collateral vessels are present. A fourth heart sound due to hypertension induced left ventricular hypertrophy may be present. Brachial femoral pulse delay if measured is typically present with diminished femoral pulse. In the majority of the patient, chest X-ray reveals notching of the third, notching of the third of posterior third of the third to eighth rib represent bony erosion due to enlarged intercostal arteries. A classic 3 sign is created by indentation of the aorta with pre and post stenotic dilatation may be present. Got it? Okay. Other option like Turner syndrome carries the association with kyphoscoliosis, which is characterized by curvature of the spine in two planes, anteroposterior and lateral. Approximately 30% of the patients with Turner syndrome will also have coarctation of the aorta. However, is commonly Turner syndrome is only seen in women. Choice B, diffuse vascular calcification are seen in patients with premature atherosclerosis and in those advanced renal disease. There is no such history in this patient. Prompt right atrial contour is often seen in Epstein congenital abnormality, apical displacement of the tricuspid valve with atrialization of the right ventricle, and patients with uh, long standing patients with long standing coarctation of the aorta may develop left-sided cardiac enlargement, but right-sided cardiac enlargement is not typical. Upturning of the cardiac apex is boot-shaped heart occurs in TOF due to pulmonic stenosis and consequent right ventricular hypertrophy. Patients typically present with cyanosis and uh, early in life. Okay.
Right.
Okay, it's cardiac tamponade. So this patient has Beck triad, hypotension, jugular venous distension, distant heart sound, and low amplitude QRS complex on ECG. Low amplitude QRS complex on ECG findings consistent with cardiac tamponade. Acute tamponade is a potential complication of the cardiac procedure. Acute tamponade is a potential complication of the cardiac procedure ablation, which may cause bleeding into the pericardial space. As blood loss or fluid fills the low compliance pericardial sac, Pericardial pressure increases and compresses the cardiac chambers. The relatively low pressure right sided chambers are affected persistently affected with restricted diastolic filling of the right atrium and the right ventricle. As these chambers are unable to fill, less blood is pumped to the left side of the heart and cardiac index decreases, resulting in hypotension and obstructive shock. Because the obstruction to the blood flow is primarily right sided, an absence of pulmonary edema is expected. Okay, we know this. Next. Okay, look at the picture and tell me your diagnosis. What should be? Because it's gangrene, and this gangrene may not be saved by anything else. Like, look, there is no pulse. So this is the gangrene. There is no pulse, so amputation is the choice. Yes. Okay. Okay, it's cardiac tamponade. This patient's uh, this patient most likely has post-operative cardiac tamponade, a relatively rare but important early complication of CABG. Rapid accumulation of blood in the limited pericardial space leads to increased diastolic pressure. The increased diastolic pressure in the chambers of the left heart, severe impairment in venous return. Patients typically have evidence of shock and hypoperfusion. The classic findings: Beck's triad, hypotension, elevated JVP, distant heart sound. Characteristically, there is elevation and equalization in the intracardiac diastolic pressure, right atrial, right ventricular, pulmonary, capillary, left atrial pressure as uh, shown on the patient's pulmonary artery catheterization. Cardiac tamponade can rapidly lead to cardiac arrest if left untreated. Urgent echocardiography to confirm the diagnosis and can identify moderate or left pericardial effusion, right atrial diastolic pressure, right ventricular diastolic pressure, highly specific for tamponade, and bowing of the interventricular septum into the left ventricle during inspiration. Immediate percutaneous or surgical drainage of the pericardial fluid relieves the intrapericardial pressure and leads to rapid improvement in symptoms and hemodynamic status. Okay, that's it. Okay, bye bye.